I hope I'm audible and visible. Yeah. So welcome to this session. It's a session especially for the NEET PG, a video-based series in dermatology. So I'm Dr. Jazeer, your dermatology faculty at PW Meded. And today I'll be discussing about 10 MCQs, all video-based MCQs. And we have one more session that is coming up in another couple of days. And so that we are getting familiarized with the new exam pattern. Like as you know, in the last FMG exam, there were about 10 to 12 questions in video-based. Even though we did not get any questions in dermatology, but in the coming days, we have to be well prepared about it, right? To start with, let us begin with the first MCQ of the day. Now, this is the first MCQ. The infant that is shown in the image has a thick scaling that is adherent to the scalp. What is the most likely diagnosis? And to play this video, let's see what is the presentation in this child. So this is the presentation. Very good evening, 𝐒𝐿𝐿𝐿𝐿 Thank you for confirming. Now let's see this video once again. Now this is the video of a infant, and this infant has developed some crusting in the scalp and there is some thick adherent scaling, right? So what do you think this is going to be? Is it Tinea capitis? Is it a infantile seborrheic dermatitis, atopic dermatitis, or scalp psoriasis? So Anuj says the answer should be B. I hope all of you agree with Anuj, right? So this is what we call it as a cradle cap, right? So in cradle cap, what you see? You can see that the similar to what we can see like dandruff in adults. Similarly, a child or an infant can develop dandruff. So whenever an infant develops dandruff, we call it as an infantile seborrheic dermatitis. It also has one more name, and the name being cradle cap. That is going to be cradle cap. And since it is an infant, very less likely that can be a psoriasis, because later on for your exam, if you get a thick adherent scaling in the scalp in an adult, at that time you will have to think about psoriasis as well, right? So Hrutik is also answering it as option B. So absolutely right. So this should be infantile seborrheic dermatitis, option B, which is the right answer. Okay, thank you for confirming your answers. So now let's see another one. The video shows a congenital, unilateral, sharply demarcated, reddish purple patch over the face that had persisted since birth and gradually darkened with age. What is the most likely diagnosis? Is it associated with any vitamin deficiency? See, Anuj, no. Seborrheic dermatitis does not have an association with any vitamin deficiency. It can be because of an hypersensitivity reaction to a fungus like Malassezia furfur, which is present in our body, and that is called as seborrheic dermatitis, right? Now here, I don't have this video in the slide, but I'll just show you the video what I'm supposed to show here. Yeah, this is the video which we are talking about. It's a child again. You can see a reddish purple color patch in the face, right? So when you see a reddish purple colored patch in the face, what is this? In the MCQ says that this lesion is present since birth. And to come back to the video once again, if you have seen this, we'll go back to the MCQ. I hope this video is all clear. Shall I go back to the MCQ now? Yeah. Now going back to the MCQ, the video shows a congenital, unilateral, sharply demarcated, reddish purple patch over the face, persisted since birth, and it has become darkened now. Is it an infantile hemangioma, a port wine stain, salmon patch, or angiokeratoma? I'll just give you a few seconds for you to answer in the chat box. Salmon patch. Salmon patch, okay. But is it really a salmon patch? How many of you agree to a salmon patch, or does anybody have a different answer? Answer C. Okay. Yashashvi is also saying salmon patch, angel's bite. Okay. C. Okay. So the reason why I'm just waiting for the right answer here, yeah, finally Sandeep Kumar is answering it as port wine stain. Now remember, yeah, Ashush Diary is also saying port wine stain. Yeah, correct. Now listen. Um, After some time, I'll show you a video of salmon patch as well. Remember that in case you see port wine stain, remember P is port. Port means Portuguese red wine. Okay, it is Portuguese red wine spilled over the face. Imagine something like this. So Portuguese red wine. What should be the color? The color should be something like this, bright red in color, right? So something that is bright red in color and it's a large patch which is seen over the face, it is most likely to be a port wine stain. Because later on, when I'm going to show you an image or a video of a salmon patch, you'll understand, because salmon patch or an angel's kiss is usually seen over the forehead. That's the most common site. It is not that dark like what you can see in a port wine stain, because port wine stain is going to be bright red in color and it is persistent. It is going to be present since birth, persists throughout life. Now you can remember it like this. P for P. So what are the P? One P is port wine stain. The second P can be it is present since birth. And the third P can be it persists throughout life. So that's going to be a port wine stain. Yeah, very good, Yashashvi. The salmon patch, it actually disappears throughout, I mean, after a certain age, right? Asta, I'll just show you a salmon patch video in some time because I have another MCQ as well today, right? So by that time, I am sure that your confusion will be cleared. So now moving to the next one. Yeah, salmon patch is temporary. Now moving to the next one. The next one says that a patient shown in the video has a well-defined, non-scarring, patchy hair loss over the scalp. Which of the following findings is most characteristic of the condition? Now, let me just play this video for you. So you can see that the examiner is seeing this lesion over the scalp. The scalp is having a well demarcated, right, with a very active border, a well demarcated patchy lesion over the scalp. It's a patchy hair loss. The MCQ itself says that it's a non-scarring alopecia, non-scarring alopecia in the scalp. Now, first, before we go into the answer, let us see what is the diagnosis here. So only if you know the diagnosis, you'll be able to tell me what is the characteristic of this lesion, right? So what's the diagnosis here? Very good. Blog, Anuj, all of you are saying the diagnosis is alopecia areata. I completely agree with you, because why? Well-defined patchy alopecia in the scalp should be an alopecia areata, right? So in alopecia areata, I can see the entire chat box. All of you are saying the answer should be B, that is exclamation mark hair. Absolutely agree with all of you, because in an exclamation mark, what you see when you do something called as a trichoscopy. What's a trichoscopy? Trichoscopy is a microscopy of the hair, right? So once you do a microscopy of the hair, you can see that the hair that is present towards the periphery of the lesion, this hair will be having a appearance like, it will be having an appearance like a exclamation mark. Isliye we call it as an exclamation mark here. Like all the other options, let me go option by option. Like bamboo hairs. Anybody in the chat box who can answer, where do you see a bamboo hair? Bamboo hair. Probably you must have learned this in hair shaft disorders. So bamboo hair is seen in a condition called as Netherton syndrome, right? Bamboo hairs can be seen in Netherton syndrome. And the second option is exclamation mark hair. It can be seen in alopecia areata. Anuj, I agree with you. There's a swarm of bees appearance in alopecia areata, and that can be a histopathological examination finding. Anybody in the chat box who can answer, where do you find this corkscrew hair? Corkscrew hair. The clue for you is it is associated with a vitamin deficiency. Is it vitamin A, B, C, or something else? Seen in corkscrew hair? Yeah, it can be seen in vitamin C deficiency. Can be seen in vitamin C deficiency. Very good. And the last one is ball and socket hair. That is also seen in a hair shaft disorder. It's called as trichorexis invaginata. Right? It is seen in trichorexis invaginata. So that's it. So Yashasvi, Michael, blog, all of you are answering it as corkscrew hair that can be seen in vitamin C deficiency. Excellent. So now let's go to the next question now. Going to the next question. Now here, a patient presents with a skin lesion as shown in the video. The lesions are annular plaques with an inverted saucer appearance, characterized by a normal appearing skin in the central part and a sharply elevated inner margin. Sensory impairment is noted over the lesions. What is the most likely diagnosis? Now see, whenever you see that there is a lesion, be it a patchy lesion or be it a plaque lesion, if there is a sensory impairment, okay, or a sensory deficit, the first disease that should come to your mind should be a leprosy, right? Now just see the options. The options are all different types of leprosy. Now the task is we have to identify the type of leprosy that is shown in this video. And there is one very important clue in the MCQ here. The MCQ says there is a inverted saucer appearance. So let's see the options one by one. And before that, let's see the video. So these are the video that shows that the patient is having multiple hypopigmented, isn't it? Or plaque lesions in the body, right? And these lesions, what is the appearance of these lesions? They take a inverted saucer appearance. So when you learn about leprosy, it's important like to understand what are the characteristics of the lesion. The characteristic of a tuberculoid type of leprosy. Let's go option by option here, right? So the option A. So many of you are saying the answer is BT type of leprosy. So let's see whether it is BT. If anybody has a different answer, feel free to answer in the chat box, right? Towards the end, you will know what is the right answer. So let's start with option A first, tuberculoid leprosy. What happens in a tuberculoid leprosy is the patient will have a hypopigmented lesion or an annular lesion or a erythematous lesion, but with a saucer right way appearance. So if there is a cup and a saucer, the appearance is going to be saucer right way up. So ये तो नहीं हो सकता, right? It's not going to be a tuberculoid leprosy क्योंकि MCQ में already we have a clue. It has an inverted saucer appearance. Now going to option B, that is borderline tuberculoid type of leprosy. And I can see in the chat box that at least, not at least 3 or 4 of you have already answered that it is a borderline tuberculoid. Now in borderline tuberculoid, what is the type of lesion that you see? You can see satellite lesions and pseudopodia. If you remember satellite lesions, what are satellite lesions? Smaller lesions that is going to be seen around the main lesion, right? And pseudopodia means there will be some finger-like extensions. यहाँ पे तो कोई finger-like extensions नहीं है, right? It is only having an inverted saucer appearance. So it cannot be borderline tuberculoid because the MCQ does not mention satellite lesion. The MCQ does not mention pseudopodia. Less likely, right? So yeah, now Rahul is coming with a new answer. Now let's see what is the next one. Borderline leprosy. See, borderline leprosy. Now see this lesion. This is where you can see an inverted saucer appearance. Sometimes this kind of an appearance, especially the first lesion here, okay, ye lesion, right? This can be considered compared to an inverted saucer. Sometimes compared to a Swiss cheese appearance or a centrally punched out lesion. Swiss cheese appearance it can resemble, right, from this video, or it can be an inverted saucer appearance. So the correct answer here should be a borderline leprosy. So guys, important MCQ. So please don't make a mistake on the day of the exam. Very important that you correlate each type of leprosy with a certain characteristic. And the characteristic of borderline is inverted saucer appearance, Swiss cheese appearance, or a centrally punched out lesion. And the last option is lepromatous leprosy. So what is the type of a face that you may see in a patient who is having a lepromatous type of leprosy? Mostly क्या हो सकता है, अगर trunk का image है या फिर video, in the trunk you will be able to see multiple small hypopigmented patches in the trunk, right? In the face you will be able to see multiple nodular lesions in the face, and it has a name. The name of the lesion is called as a leonine facies or lion-like face. A leonine facies or lion-like face. Yeah, very good, Rahul. This kind of lesions, they are also called as a geographical appearance, like the maps, right? Fish Diary, all of you. Afsa, all of you are answering. Leonine facies. Excellent. So please make sure that you get this one right on the day of the exam. So now moving further to the next question. A patient presents with a diffuse erythema and a scaling which involves almost the entire body surface area. As shown in the video, what is the most likely diagnosis? Now, the moment you see the sentence, you must be able to understand that there is a diffuse erythema, which means the entire body is red in color. And there is an associated scaling as well. So let me play this video for you. In this video, let's see. Now the patient is having some generalized skin condition, right? So it's a generalized lesion that you can see. The entire body is having a lot of scaling, and the body, the color is also turning red in color. So diffuse erythema, scaling that is present in a patient. Can it be a generalized pustular psoriasis? Could it be erythroderma or a Steven Johnson syndrome or an Ichthyosis vulgaris? Let me see what is your answer. Yeah, happy that most of you are getting this one right, because this should be a erythroderma. Because what is erythroderma? Erythroderma by definition, it is more than 90% of the body surface area which turns red in color, right? So when a patient comes to you, when the entire body, 90% of the body has turned red in color, it's called as erythroderma. And please remember, this erythroderma, it can be associated with various conditions. It can be associated with severe atopic dermatitis. It can be associated with psoriasis or something like a cutaneous T-cell lymphoma, right? Mycosis fungoides. It can be associated with various conditions of the skin. So it's not a single disease entity. It is an associated condition with some dermatological diseases. But how do you diagnose erythroderma? When the body surface area, 90% is going to turn into a red color, right? And someone had answered as a generalized pustular psoriasis. It's a good thought process, I would say, because in generalized pustular psoriasis, the entire body may become erythematous, but a very important finding is there, because the name itself says pustules, right? So in a generalized pustular psoriasis, the MCQ or this video should be showing you some pustules in the skin. But here, when we see this video, we cannot see any pustules in the skin. Mostly what I can see here is scaling and erythema of the skin, right? So since I couldn't find any pustules, the answer should be a erythroderma. I hope it's clear. Now let's move to the next one. A patient presents with a irregular lesion with the indistinct margins and minimal scaling after using a steroid containing cream for several weeks. What is the most likely diagnosis? Now we have a patient who is coming to you with some irregular lesion. The only clue that we get from the patient is the patient has been using a steroid cream, right? Options are eczema, tinea incognito, psoriasis vulgaris, and discoid lupus erythematosus. Let me play this. So once we see this, we can see that there are huge lesions in the trunk, right? Extensive lesions in the trunk. And some of these lesions are showing some crusting now, isn't it? Some are become plaque lesions, but these are non-specific, because in the anterior part of the body, you can see some crusting. In the posterior part of the body, you can see that there is some erythematous plaques, which means the characteristics of the lesion is lost, and this lesion is showing no improvement with steroid creams. Now see, in case the answer was eczema or a psoriasis vulgaris or even a discoid lupus erythematosus, it should be responding well to a steroid cream, because steroids can be used in all these conditions. Now what's the answer? The answer here, very good, Dr. Asif Ali, Brooks, Sensi, Afsa, Sandeep, all of you are answering it right. Happy to see that. It's called as tinea incognito. So this could be that a patient has come to you with a tinea corporis. What is tinea corporis? It can be an extensive tinea infection, a fungal infection of the trunk, right? So a fungal infection is always expected to be treated with a antifungal agent, never a steroid. Because once you are going to use a steroid to treat a fungal infection, what happens? All the characteristics of the fungal infection will be lost. Like the patient will not show any scaling, the patient may not complain of any itching anymore, and the lesions may look something non-specific like what you can see in the screen, right? So this is called as tinea incognito, a steroid modified tinea. It's called as tinea incognito. Shall I move to the next one? So moving to the next video now. The lesion shown in the video most commonly disappears spontaneously by. So now here itself the MCQ says that whatever lesion this infant is having is going to disappear. We just want to see by what age is it going to disappear. Let me play this video for you. Now remember our first MCQ, we had a infant or a newborn who was having a bright red color lesion in the face. Now here you can see that there is a red color lesion, and this red color lesion is present over the forehead of this infant, right? Now what is this? What is the diagnosis here? I'm getting answer as A, C, but before you go for the answer, can you tell me what's the diagnosis? If you want diagnosis clue, I can give you some clue like port wine stain once again. Salmon patch as another clue. The third clue would be a capillary hemangioma or an infantile hemangioma or a strawberry hemangioma. What's it? Yeah, Afsa says that it's a salmon patch. So all of you agree? Excellent. So here, please understand. Yes, very good. Michael, Sush Daily, all of you. Yeah, this is a salmon patch. The basic difference here is that a port wine stain is going to cover almost the entire part of the face. Usually it is going to be unilateral in most of the cases. Bright red color hoga, kahan pe? In a port wine stain. Whereas salmon patch is also called as an angel's kiss. So just try to memorize it in this way. When will an angel kiss the baby? The angel would kiss the baby at birth. Isliye, the lesion that you can see in the forehead is going to be seen since birth. The angel kisses the baby over the forehead at birth. ऐसे imagine करो, ठीक है? And now, where do you see the lesion? Forehead. When do you see the lesion? Since birth. And it's an angel's kiss. An angel's kiss cannot be bad, right? So it is going to disappear. So by which age does it disappear is the question. And the correct answer here should be, so I can see multiple answers in the chat box. Some of you are saying B, some of you are saying C. What is the answer? The correct answer is 1 year of age. So let's consider an infant cute up to 1 year, right? So after 1 year, the salmon patch will disappear. So angel's kiss, present since birth, an angel's kiss cannot be bad. So it disappears by 1 year of age. And that is called as stork bite, salmon patch, angel's kiss. Any of these names, see all these names are the single entity, right? So it is going to be 1 year of age. So that's about this MCQ. So now let's move to the next one. So moving to the next MCQ, this says that the video shows generalized fine polygonal scaling predominantly over the extensor surfaces of the limbs with a sparing of the flexures. What is the most likely diagnosis? And I'll just play this video as well. So what I can see from this video is that the patient is having a very dry skin, right? So there is an extreme dryness of the skin and multiple areas are having some crazy pavement like pattern or something, right? There's a lot of scaling can also be seen. But if I give you one clue, that does it look like a fish-like scaling? Dry skin, fish-like scaling? Yeah. So in which disease can you see a fish-like scales? So you can see a fish-like scale in a condition called as ichthyosis, right? So it's seen in a condition called as ichthyosis. So when you see all the options now, in these options, A, B, C, all the three options are ichthyosis. The only option we can rule out is a pityriasis rubra pilaris. So let us rule out pityriasis rubra pilaris. Alright. Now we are left with three options: X-linked, Ichthyosis vulgaris, lamellar ichthyosis. Now it is your turn, and the biggest clue that you have in this MCQ is that these lesions are predominantly present over the extensor surfaces of the limbs, and it is sparing the flexures. So Piyush is so confident that he's like B, 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 right? So is it B? Does all of you agree? Yeah, very good. So here the correct answer is going to be option B, that is Ichthyosis vulgaris. So remember few points in Ichthyosis vulgaris. It is an autosomal dominant disease, right? The patient will have a dry skin, which means there will be a fish-like scaling over the skin. The third point is that the most important point here is the lesions will be predominantly seen over the extensor surfaces, and there will be a sparing of the flexures. So with all these things, a defect of filaggrin, the answer should be Ichthyosis vulgaris. And for whoever has got this one wrong, especially thinking about other answers, see, in case the patient had a X-linked ichthyosis, the MCQ would have told you that the patient is having the extensor involvement as well as the involvement of the flexures. X-linked ichthyosis में क्या होगा? Extensor भी involve होगा, flexures भी involve होगा, right? That is called as X-linked ichthyosis. Lamellar ichthyosis का presentation is entirely different, because a baby is born with a membrane coating at birth, right? So when a baby is born, you can see a shiny membrane throughout the body. In few days time, the membrane can get peeled off, and once the membrane get peeled off, you can see a very dry skin underneath. That's called as a lamellar ichthyosis, right? So here, this one, the right answer is going to be Ichthyosis vulgaris because of the presence of extensor surfaces. Shall I move to the next one? Yes, Anuj, steroid sulfatase का deficiency होगा. Very good, Rahul Jain. The lamellar ichthyosis is also called as collodion baby or the collodion membrane. The collodion baby or the collodion membrane. Very good. Moving to the next one. A 32-year-old man presents with asymptomatic lesions over the extensor aspect of the elbow, as shown in the video. Gentle scraping of the lesion is demonstrated. What is the clinical sign? So before we go into the clinical sign, let's see this video. What's happening? What I can see here is a patient is having a erythematous plaque lesion, right? A red color plaque lesion, and over the plaque lesion there is some scaling as well. And what is being done is we are just trying to scrape over the lesion very gently, right? What is this clinical sign? Are we talking about a Nikolsky sign, Darrier sign, Auspitz sign, or a dimple sign? Excellent. I guess nobody is getting this one wrong. So here, all of you are answering it as C. The correct answer is called as Auspitz sign, क्योंकि यहाँ पे diagnosis है psoriasis. Psoriasis, and this is a very typical image, right? Not image, but a video. Again, because in psoriasis, you can see that the patient is having a erythematous plaque lesion over the extensor surfaces. Over the extensor surfaces, there is some whitish scaling also. And instead of using your fingers, like if you take a glass slide and you're going to scrape over this lesion, this is called as Auspitz sign, because you'll be able to appreciate a pinpointed bleeding spots on scraping the lesion. So this is called as Auspitz sign. And in this MCQ, multiple signs has been mentioned. Nikolsky sign, jahan pe if you are going to apply a tangential pressure, the skin peels off. That's called as a Nikolsky sign. It can be seen in diseases like pemphigus vulgaris, pemphigus foliaceus, burns, isn't it? Staphylococcal scalded skin syndrome. All those things can have a Nikolsky sign. Can anybody answer where do you find a Darrier sign? Darrier sign. Yeah. Darrier sign can be seen in a condition called as urticaria pigmentosa, because that is more common in children. Because once you're going to stroke over the patient's skin, if the patient is going to develop an urticaria, so this is called as a Darrier sign. After stroking over the skin, if the patient is going to develop, very good Anuj, Michael, Dr. Asif, all of you are answering it right. It is all seen in cutaneous mastocytosis. And this cutaneous mastocytosis is called as urticaria pigmentosa. Excellent. And the last one, that is dimple sign. Any answers for dimple sign? So what is dimpling? Like what you can see in the face, right? So once you are going to pinch around a lesion, if the lesion is going to go extend beneath the skin, that's called as a dimple sign. It can be seen in dermatofibroma. It can be seen in dermatofibroma, right? Excellent. And I guess this is a small confusion here. Please remember that dimple sign is not seen in neurofibromatosis. The thought process is correct because if while you're going to press over a cutaneous neurofibroma, the cutaneous neurofibroma goes beneath the skin, just like how you insert a button into a button hole. So there the sign is not dimple sign. There the answer should be a buttonhole sign. It should be a buttonhole sign. Okay. Yeah. So now moving to the next one. Now here, let's see this question. A patient is, yeah, that is going to be buttonhole sign. Correct. The patient presented with itchy annular concentric lesions as shown in the video. What is the most likely diagnosis? Now let us see how is a patient presenting to you. Now here we can see that the patient is having multiple annular lesions, right? What is the meaning of annular lesion? Annular lesion means rounded lesions, but these are multiple concentric. One concentric means one after the other. So multiple concentric lesions can be seen. And the MCQ says that these are itchy lesions as well. Now let's see the options. No worries, no worries. It is okay to get confused. Okay. Because once we are going to deal with these kind of video based questions, there are two types of things that you need to expect. One is that we first need to get more familiarized with the common things first, right? Common things first, and then we go into those uncommon things, right? So once we are able to recognize these kind of patterns, that what is an eczema, what is going to be a tinea, then only we'll be able to judge the other differential diagnosis as well. Now here when you see, you can see that, yeah, see Anuj is saying that after seeing this lesion, it looks like a nummular lesion. It's a good thought process because nummular lesions means these are rounded lesions, coin-shaped lesions. But anywhere in nummular eczema, did we learn that there'll be multiple concentric rings like this? Maybe we have not discussed anything like that, right? So I'm getting answers like Tinea corporis, nummular lesion, option B, right? So let's see one by one. Pityriasis rosea. I guess nobody will say this one as pityriasis rosea. The reason is pityriasis rosea usually seen over the trunk. Patient को mother patch या herald patch होगा and multiple erythematous plaque lesions होगा. यहाँ पे कोई plaque lesions नहीं है. It's going to be itchy annular lesions. So that is easily ruled out. Second one is Tinea corporis. What goes in favor of Tinea corporis here is the itchy lesion, rounded lesion, and that is also the correct answer here because there is a subtype of Tinea corporis where these multiple concentric lesions can be seen because it is called as Tinea centrifugum, right? So it can be called as annulare centrifugum and all these names. So this is again a type of Tinea corporis where a patient can present with multiple concentric rings. Centrifugum is right, annulare, all those things. Now in this patient, if you do a KOH, the KOH will be positive and you can treat the patient with antifungal agents. The next one, nummular eczema, less likely because nummular means you'll get a single coin-shaped eczema. And the last one is leprosy, very less likely because there is no mention about any deficit like sensory deficit or nerve involvement or anything like that. So leprosy can be easily ruled out. So that's it. I guess we have discussed only 10 questions today. So it's a short session. So day after tomorrow, we have one more session coming up. So we'll be adding more video-based sessions to our YouTube things and as well as to the notes as well, to the videos as well. I hope it was helpful to all of you. We'll be coming up with more clinical science. So the basic idea in the upcoming sessions is that all those clinical science that we have in dermatology, we'll bring all of them as a video-based question and also the common findings of common diseases as well, right? So thank you so much for being a very interactive crowd today. So do let me know if you have any feedbacks or what all things you would like to get included in the upcoming sessions. If not, we'll call it a day and we'll see you again for the next session day after tomorrow. Thank you so much.